high-level recommendations, of course, anytime we are considering a patient for surgery at all, we have to think about big picture issues in terms of the patient's candidacy for any type of operation. What is their performance status? What is their pulmonary function? Are they able to lose the amount of lung needed? Will they tolerate single lung ventilation? Do they have any major contraindications to major surgical procedures, such as severe heart disease or other medical conditions that make surgery higher risk? So, of course, those are issues we consider. We don't typically consider age to be a sharp cutoff or an exclusion criterion from surgery. But at the same time, in the space of stage 4 lung cancer, we've seen substantial benefits for local consolidative therapy, which can be performed with surgery or radiation. And so we need to be thoughtful about those patients in whom we offer surgery and those in whom we offer radiation, because as of yet, we don't have definitive evidence comparing the two side by side. We can look retrospectively at groups of patients who received surgery and those who received radiation, but we understand there's a very substantial selection bias and that the healthier, stronger patients typically get surgery. So we don't know if one is better than the other. So while age is not typically a cutoff, I would say that for patients who are older, who do have some medical comorbidities, consideration of radiation as local consolidation is very much appropriate. I would say that in this era, we do not use the number of metastases as a strict cutoff. We will operate on people who maybe have more than 3 sites of metastases. We will offer surgery even to people who have had a history of a previous pleural effusion, provided that it has responded well to systemic therapy. I think it's important for us to acknowledge that there are definitely different subgroups of patients. For example, those who have driver mutations. Maybe they've had extensive bony metastatic disease and had a pleural effusion and responded really well to targeted therapy to the point that their residual disease is only the primary tumor. That is a very different picture of polymetastatic disease than someone who has no driver mutation and has no drug therapy that can help keep their disease controlled and maybe still has polymetastatic disease that is progressing throughout their body. And so we don't have strict cutoffs such as polymetastatic disease is an exclusion criterion, or pleural effusion is an automatic exclusion criterion, but it's more the big picture and how well we think the biological control is. And I would say the best candidates are not determined by how extensive their disease was at the beginning, but do we have a window where they have really good biological control and we can manage the primary tumor to hopefully keep drugs that are working well, working for even longer. And I think that's typically the impetus to pushing toward surgical resection for patients who are healthy and are strong and maybe have a targetable mutation or on a drug that's working well. We tend to believe that the cells that are going to be resistant to targeted therapy, those persister cells, are often also the same cells that are resistant to radiation. But you can't really be resistant to surgery. So, if we can operate on those people at a time when it's favorable to do so, I think those are the people in whom we can see benefit. But we need to be very thoughtful about the patients to whom we do offer surgery. Particularly when we're talking about those with polymetastatic disease or those really any patient with stage 4 disease in whom we're thinking about surgical consolidation. We recognize that some patients have drugs that they can be on for a long time that work really well, and some patients don't. And so ultimately, I think it's important to recognize that for each patient, every site of disease that they have needs to be either addressable by some form of local consolidation or needs to be addressable by a drug therapy that they can stay on long term. And if they don't meet those criteria, then it's not clear that there's a benefit to operating on any portion of their lung. So, for example, even if a patient doesn't have a drug therapy that they can be on for a long time, if their only site of disease is the lung area that's going to be resected and maybe one other site that's going to be radiated, then they would be a great candidate. Likewise, if there's a patient who has extensive disease, but all of it is responding well to a drug that they can stay on for a long time, they may also be a candidate. I think the key here is that there's no hard and fast rules of the people who can definitely have surgery and those who would definitely be excluded. But we clearly do understand in our recent clinical practice guidelines that among patients with oligometastatic lung cancer, lung resection can be used as a consolidative therapy, and it may offer therapeutic benefit as seen by prolonged survival and progression-free survival compared with best supportive care or maintenance therapy when we look at local consolidative therapy overall compared to best supportive care. And we do think that lung resection should be considered as a methodology of local consolidation in patients with oligometastatic disease. That discussion, that conversation, that consultation is the most important first step, because the concern is not that not enough patients are being evaluated for surgery and going to surgery. The concern is that it's not even being considered for far too many patients.